The 46th AMSI National Conference, Indore. We are about to begin with our oncology session in a short while. We have with us our chairperson, the first chairperson for this session, the name that needs no introduction in the field of maxillofacial surgery and oncology. Dr. Nitin Bhola, sir, I invite you to please chair this session. We'll have Dr. Mayank Pancholi joining us in a short while for chairing the session. Senior surgical oncologist from Indore.
Very good morning, ladies and gentlemen. I welcome you all for the first session of the second day of this conference. And we have a galaxy of speakers, very renowned, who have come here to share their knowledge. Let me start the session and invite Dr. Moni Abraham Kuriakose, who will be speaking on knowledge and skills required to be a head and neck oncosurgeon. Dr. Moni doesn't require any introduction. Everybody knows him. He's an excellent surgeon and moreover an excellent human being. Over to you.
Last night must have been quite an enjoyable session, so that must have... Oh, can I have the first slide, please? So I'm given a topic to preach on a topic of knowledge and skill sets required to become a head and neck surgeon. So if I sounds like a fatherly kind of advice, forgive me. So I will start. So this is a title which is given to me to address to this audience. So in addition to that the domains which I was asked to speak, knowledge and skills, I will also add two more skill sets required to become a head and neck surgeon, that is attitude and practice. To me, the first attitude is soul of what we do. If the attitude is right there, then the knowledge will come, skill will come. But we can have knowledge, skills, and everything unless we can practice, execute. All that become just information without any action. To put things in perspective, I'm going to narrate a story of a patient we managed some time back, and that will give a context of how to think about the entire problem. So this is a child of about 6 years old, came to us in about 2003, and that's the time when we started our head and neck program in Amrita. And this child had gone from Delhi and from Mumbai to Washington, saw a very famous craniofacial surgeon with this problem. You can see in that scan there. And this child had undergone about 4 surgeries during that 6 years of her life, and the tumors has come back. It was a fibromatosis of the infratemporal fossa, gone to the middle cranial fossa, wrapped around the internal carotid artery, and the doctor referred the patient, the surgeon referred the patients back to me. At that time, I had relocated back from US to here, and said to just look after the child, saying that just a palliative care, nothing much we can do. And this is what I thought, and I said that, okay, so we, as a standard practice, discussed this case in our tumor board. And then while I was discussing, I could see that my colleague, the neurosurgeon, Dr. Panikar's eye was focused around that infratemporal fossa mass, and my eye was focused around the skull base where the carotid is wrapped around. Two impossible type of situation from my perspective and his perspective. And when we put a cover at the skull base and asked Dr. Panikar at the infratemporal fossa and asked Panikar whether we can resect, he said absolutely not a problem. So if I put a cover at the skull base, for me infratemporal fossa is fairly straightforward. So then we thought that impossible thing can become possible, And at the same time, so this is how things started. By about 3 o'clock in the afternoon, we finished the head neck part. Then the neurosurgery came around 8 o'clock. He finished. And Dr. Iyer got awarded last night. He upped the ante. He said that, this child of 6 years old need a vascularized growth center transfer. Nobody has done in the world. So he has taken a serratus anterior with rib with the cartilage, and then reconstructed that defect. And around 8 o'clock in the morning, we had to go back. They developed a hematoma, evacuated and everything. So I was coming back from the hospital. One of my colleagues asked, Dr. Kuriakose, you are early to come to work. No, we are going back home. So that is the type of cases we need to manage as a head and neck cancer surgeon. And this is a child immediately after discharge, just about to discharge, 2 years post-op and 15 years post-op. Now this kid is doing undergraduate at Harvard University. So it just shows a positive kind of scenario. You just look at that very, very complex surgery and how the team managed. To me, as I mentioned, attitude is all about the success for us to become a profession. And the dictionary definition of attitude is a settled way of doing something. Means it's a fixed type of notion you have in thinking about a problem and so on. When it comes to head and neck oncology, we have 3 groups we need to address. One is a patient, disease, and profession. And the patients are quite different from other disciplines within the maxillofacial or ENT domain, where the patients are feared of their life. And they are feared about quality of life and so on. So it's a different kind of patients, people we are dealing. And disease, we have not even reached anywhere close to understanding cancer. So with a lot of uncertainty involved. And when it comes to profession, head and neck surgeon is just one piece of the entire puzzle, that team managing. So that is also a different mindset we require. So if I put some list of bucket list of what are the qualities within that attitude, I put that about 9 of them here. The first thing is self-confidence. Confidence is required. Imagine that child who need to undergo almost like life-threatening type of operation. We should be confident in what we do. The confidence should not be equated to arrogance. That I used to see that a lot during my training period, but slowly I'm glad to see that that's changing. And second is that humility and the ability to overcome failures. Okay, Dr. Iyer could have said that my flap will not fail. I could have said that would not have given a positive. He just took the patient back, corrected that, and that's all the problem. The third is self-motivation. If you're expecting somebody else to give the stimulus and everything, that will not really work. So it should be a self-motivated. Then all the need to acquire more skills, knowledge, everything come later. Fourth, to me, it's extremely important. Okay, I can always tell that is attention to detail. That's something which, as a community culture, we Indians need to acquire. That is significantly lacking. The chalta hai attitude, that will not work, because patient has given their life in our hands, and so we have responsibility. Everything we do, positioning patients, everything we do, that is very, very important. And team approach, I mentioned to you that we are just part of the entire team, not just the one sole person in that managing the patient. Endurance, this case is a typical example. Endurance of one surgery. Similarly, we have to endure throughout our life. We are just this morning we are discussing the Goyo and other things. A lot of people are getting out of head and neck type of discipline because of the lack of endurance. And passion is extremely important. Once you're passionate all the other things will come. And constant desire to improve, because that is not just one time point, it's a constant desire to improve, and finally the God's grace to, so that things will come in place. That is important. I just want to show you, give another example of my friend Rajiv Chowdhury. He works in Padar hospitals in between Nagpur and it's within a forest area. I used to go there for my own personal satisfaction. If you look at that, the doctor's quarters here, just lilies coming up there, putting in a very remote kind of foresty type of place. And the operation theater has got almost 4 or 5 beds stacked in the one room, managing one anesthetist, managing this 4 or 5 operation theater. So when I was there some time back, this patient came with a lot of maggots and everything, and he was slowly plucking the maggots from that patient. Remember, a medical student was there, she fainted and so on. And then, at the end, then he said, what we're going to do is that we'll resect and put a free tissue transfer. This is in a forest area. And that is a result he got. It was not motivated by nothing. He just says self-motivation, want to look for perfection. That is what he did. That is what attitude all about. Now, second aspect is knowledge. Without knowledge, nothing will, it's very important that it's very, to become a good surgeon. And when it comes to knowledge, again, 2 domains. One is the patient domain, and then the disease domain. And then when it comes to the patients, we cannot, consider ourselves or degrade ourselves as just a technician. We should take the total ownership of managing the entire patient. And to do that, we need to have the knowledge to manage the entire patient. Yesterday, Kitta was talking about the need for medicine and everything. This comes in there. And there are a few of some people who can acquire knowledge or to manage the entire patients. But to me, if somebody is going to provide me the knowledge through a structured course, that is very important. And when it comes to other aspects like disease and other areas, there is a significant and surgery, like any other skills, can be acquired. We don't have to be born with a skill set. This is something which we can learn. And then if you look at the textbook or the dictionary definition of skill is what? Ability to do something well. That well is important, not just doing something, but doing it well. How do we get that skill set? I put some list of expectations which I put it there. Surgery is an art. That's why we go into operation theater, we perform surgery. So it's a performance, okay? And the performance can be learned. And it's not just the end. If I do a neck dissection, not how many number of lymph nodes I get out. Of course, that's very important. How do we get down there? The process is equally important as the end. That is very important. And I mentioned skills can be learned, and also skills one learned should not be stopped. For example, this is Gawante's famous statement or recommendation that we should always have a coach. In sporting situation, even the most best sports person need a coach to continuously perform. Even a person with Dr. De Cruz standing and others, we also need somebody to guide us to make sure that we perform to our peak performance throughout our career. The other thing is that I've seen multiple people developing developing a new surgery while they are operating. Multiple part of the surgery can be automated. Like for example, tying a knot, it should become automatic. That comes only by repeatedly performing surgery several times, become an autonomous process. Okay, that is for the routine procedures. Okay, how do you hold the knife and everything has to be. But same time, there are areas where we need to spend time, and that is where we need to spend time, not everything. So I know I've seen the people just trying to stop every RBCs coming out. That is not so. There are areas where we need to spend time. That is important, and also economy of movement. I've seen some surgeons, just perform whatever possible to be done within that box. You do that, then come so that everything looked like a very, very seamless type of process. Economy movement is very, very important. And the other few issues is that have a plan about even a straightforward surgery. Have a plan and convey the plan to the team so that the entire team will perform. Then the last two, the engineering principle, if you think about that patient which I showed you earlier, it's very, very complicated if you think from a distance. But if you put this very, very complicated process, like let's say sending a rocket to the Mars, if you put into small pieces, which we can do effectively and combine all these smaller processes together, we can achieve even bigger and complicated procedures and process. So split up every procedures into small components which can be performed well and stitch it together as a masterly surgery. And the last thing I've seen several times, we become technicians, and technicians of hand sometimes may not be connected to the brain. Yesterday, Kita was talking about it's not just performing surgery, when not to do surgery, when to do surgery, what are the alternate steps and so on. That may be thought about that. So that is extremely important. So be a thinking type of surgeon. Then the last part is about, can you move this? Okay, yeah, practice. The last part is about practice. Unless we can execute our knowledge, execute our skills in an effective fashion, we are not a good head and neck surgeon. So how do we do that? The first thing is that develop a conducive environment in what we do. Operation theater, making shouting and screaming, that's not the best way to create a good environment. Now, I've seen people doing that. If you do that, be pitiful to that person, because the reason is why somebody shouting is because of lack of confidence, or it's because of some other problem, rather than if you have a confidence in what you do, the calmness will come along with that. And that is about surgery, but entire clinical care of the patient also develop a creative type of environment. And as I mentioned before, the patients and family we are dealing with are totally different from aesthetic or trauma or orthodontic surgery. Here the patients are giving their life to us come with a lot of fear, and that fear will reflect as maybe anger and other type of expressions that we should appreciate and understand that is just a reflection of their fear. And team approach is very important. Head and neck surgeons lead the team. Lead the team means there are different leadership qualities. One of the leadership qualities I really admire is something called a servant leadership. Be part of that. We should be prepared to do everything of others can do. So develop a leadership quality so that the entire team can work together. And the other aspect is about disease. There are many unknowns, and if you're really passionate about the disease or the problem we are addressing, we should solve the problem. Research is extremely important, and try to at least solve 1 or 2 problems in our lifetime in the disease which we are managing. Just don't be a technician. Then the last 3 points about the institutions, there should be a congruence between you and the institution, both ideologically as well as various other features. Let us say that I may be working in the government kind of organization, and if you are working in a government or corporate or whichever sector, you should develop a partnership with that organization so that both entities should benefit. At the moment you feel that you are not benefiting, means and the institution is not benefiting, it's time for you to get out. Making chaos in that situation is not the appropriate thing to do. And in every setup during our evolution as a surgeon, there are different requirements for us, and the requirement for the institutions also can be vary, but every time we should be able to contribute to the overall growth of the institution as your own personal growth. So there should be a congruence between the two so that there will be a happy type of environment. And profession is very important because it's our job is not to become a best surgeon in the world. Along with that, we need to bring other surgeons along with us so that the disease which you are dealing with can be improved. So knowledge sharing is very important. Be a good teacher and be accessible to your peers so that they can reach out to you and in the care of the patient. And finally, try to develop a societal impact so that disease we are managing can have a long-term impact. So finally, ladies and gentlemen, my next slide. Can I get the next slide, please? Okay. So to summarize, ladies and gentlemen, I think let me come to that. Oh, next slide. Yeah, okay, good. So I spoke about the attitude, knowledge, various components I mentioned to you about, the skill sets and the practice. I have about 1 second, just mention about this global oral oncology diploma program. AOCMF and IAO is going to start. I do wish that many of you will show interest and participate in this online diploma program. Thank you very much for your attention.
Thank you, Dr. Moni, for that exemplary lecture.
We have our next eminent speaker from Chennai. She is a well-known maxillofacial oncology surgeon. Please join me in welcoming Dr. Shubhra Chauhan.
An honor to speak between 2 stalwarts in our field. One being I'm trained under, and of course the other needs no introduction. So it's more of a theoretical topic, nothing too many of diagnostic current trends happening. So for both the audience, like the postgraduates and all of us who are already practicing, I'll deal into the few current trends as well as just brush through what is happening from all these years all over. So the need for diagnosis, we can't start a disease process, treatment, staging or anything for that sort. It doesn't need to be cancer per se, but anything for that matter until unless we diagnose the disease. So the need for diagnosis is major, and it needs to start from the time the patient walks into a clinic, not after doing the biopsy. You need to start thinking about the diagnosis the patient starts in. This is one of the slides. So you can see that it starts from the physical examination and then drops down to biopsy and stainings, imaging, and nowadays spectroscopy, biomarkers coming into play. And lastly, not the least, the gold standard, the histopath. So this is the general workup we all go through, and we need to be always careful that we don't forget the first initial portion, that is the examination. Never forget that. Just some of us, as we keep practicing quite oftenly, we start landing up into just like the patient walks in without just do a biopsy quickly. We have these cross consultations over phone and we just order a biopsy. So never forget to do the first step before we land up into the further following steps. And for all the juniors, just remember, especially when you are dealing into oral cancer, we need to stage our patient in oral cavity, not just labeling the patient CA oral cavity and just wash out the patient. Make sure you know your subsites well, the other 7 subsites. And another point is always remember the difference between your oral tongue and the oropharyngeal tongue. That's the anterior 2/3 and the posterior 2/3 divided by the circumpalate papilla, because the treatment per se changes totally. When you're dealing into the oral tongue, we're going to take the treatment plan from the oral cavity. The moment the tumor lands up in the posterior portion, the whole ballgame changes. It's more of chemoradiation. So why I'm putting this slide is that this needs to be mentioned in your clinical examination. You need to diagnose that at the time of patient walking into your setup. So next comes what? You can be very obviously the first person who's seeing the patient. This tumor doesn't need introduction, you don't need to diagnose it as a clinician. Even the patient walking into the clinic already knows that he or she has a tumor sitting in. And this is little on more of a frozen tongue, which is an indurated lesion. But sometimes you get these small indurated lesions, which are on clinical, just eye examination may not pick up, but only when you use your fingers, and that's when you catch them. So never forget to palpate your tumors. And some of these very similar thin, small lesions, small red and white patches, they may look very minimally suspicious, but a small eye of suspicion, a small induration around the lesion, please don't stop. Please go ahead with your next stage of diagnosis of biopsy. And never ever forget, see, from the background we are all coming, never ever forget to examine the neck. That is the key for the next examination when you're dealing into oral cavity. Some of us have this whole, from the time we have been trained, just to see the face, the oral cavity, and we walk off from the patient. So never ever forget to examine the neck. That's another key important. These have almost been waded off, especially when we have to order higher investigations when we are diagnosing a patient in pathology, like CT, MRI, and now PET has come quite well. So radiographs are not really needed, and I will totally not recommend patients undergoing unnecessary investigations. Lot of, I am working in an institute, and a lot of them, some of them have a habit that anyways we want to do an X-ray, we want to do an OPG. The patient is going to go in for a high investigation. Why do you want to burden the patient with and traumatize the patient by going into multiple investigations? So they are almost obsolete. I will not say obsolete totally, but for when you're working a patient more for a higher end investigation, I think we can avoid them at the time. So screening has come in majorly. It's not my work, of course, but I'm just trying to put up all the work which is present in literature. For diagnosis, the current trending involving. So why? Because it helps in reducing the burden, individual burden, decreasing the mortality, morbidity, and improving our quality of life. So all these are happening in screening. If you're able to screen the patient, all of us know, if we need the patient screened, we catch the patient early stage, we have a good prognostics of the patient. We are happy as a surgeon, the patient's happy as a patient. The screening, of course, started with the first thing, that's the visual oral examination, and the gold standard being biopsy. But visual oral examination is very, very doable, still very doable in screening, but then it has undergone a lot of new trends, like multiple techniques to increase the efficacy. That's like using tissue autofluorescence, then multiple vital staining devices. So there's a whole list. You have this chemiluminescence, you have Visi lights, and then you have this TF-AF combination. It's called the Identify 3000 lights, and a lot of things coming up. So that's basically to increase the efficiency when we are screened. So VOE doesn't go out of play, but then it increases our VOE. And then in literature, there's also work on salivanomics. It's not yet FDA approved, but there are 2 commercial products available. We are checking for CD44, and the other one examining 6 salivary enzymes, because saliva is the one which is coming in contact with oral cavity tumors. So they say that instead of blood, this is a more accessible. So these studies are coming in vogue now. And the next and most important is the AI and convolutional neural networks, you can say. It's becoming a very, very powerful tool. Lot of e-health, lot of mobile networking happening. One of course, from Sir's papers from Birur et al. And then there are other papers from Argentina and Malaysia. This is from one of the Sir's, Dr. Moni's study about which used the mobile, that means the mobile phone, and they had a light which had a regular white light and autofluorescence light. They examine the patient under board. But the trick is that not everywhere we get good internet access. So they try to beat that by going in for the mobile, having the AI to screen it. Of course, later, if there was internet accessibility, it was loaded into the cloud, and then a remotely placed head and neck surgeon or a diagnostic surgeon was sitting up to reconfirm the diagnosis. So this is like how we play in a resource restrained setting. How do we overcome our findings? So a lot of advantages. It had high overall performance rate. It had quick response. Of course, the competition cost was down, and there was deep learning oral cancer screening with low socioeconomic status. Then they have this screening tool called STOP. That's for primarily for oral malignancies, where what they did was they started marking the labeling, like the white lesion with the verrucous, with ulcers, into multiple scoring system, and then they started putting a stage to it, like we have staging for oral cancer, a green label, a blue label, a yellow, orange, red. You need to start getting alert and plan a biopsy. So after these regular screening, which has undergone a lot of inventions, I will just brush through the regular work, which we regularly do. Majority of us know about it. We need to do a biopsy for a lot of us. Even a lesion like this, which may have an erythroplakia or leukoplakia, at least a diagnostic biopsy may be needed. We don't land up treating all the homogeneous leukoplakia, of course, but then the diagnosis for our benefit is needed. Very few contraindications, like a pyogenic infection or a vascular lesion. And of course, the type of biopsy deals. So just for the juniors, it runs into cytology, where you have the FNAC, and then you have the biopsies, which can be anything like a cold knife cutting, a punch, or true cut, and then the excisional. So the exfoliative cytology generally was used again for screening purpose, largely a small disadvantage where you just exfoliate some of the cells, smear it on the slide, and then they fix it and they see it. But then it has a lot of false positives, and then also in case it turns out to be positive, you always need to reconfirm with the biopsy. So it can't be the definitive diagnostic tool. And then was on a company which landed up, I think it was long before during my PG period, this company came, Oral CDX, they used the brush for the same concept, and what they said that the AI, the computer was going to read up their diagnosis. I think because of the finance which was involved in it, it didn't really pick up. And they actually tried to classify all these cytologies into class 1, class 2, class 3, last 2, stage 3, and like class 4 and 5 being the ones which are more suspicious lesions. And the most important diagnosis, which we not very commonly used when we are as a maxvac surgeon, but as a head and neck surgeon, we use very commonly is, of course, the fine needle, a needle stuck into any swelling which is more remotely placed. Multiple pricks given, basically to get out the cells. Remember that it's a cytological examination. We are trying to get the cells out into the needle, and that's smeared onto the slide. It's not a typical cut cold biopsy piece. So remember always, you need to get a good cytology sample in it. Another key problem in this is the reading. It's not very, very easy to get good cytologists. I mean, the good pathologist who can read good cytology. It's easy for a head and neck cancer center to have them, but as a common outside practitioner, it does get difficult sometimes. And more commonly, this is used when you have these small nodules maybe sitting inside a thyroid, or a large lesion or a small lesion in the neck very close to the large vessels. In those cases, we need to combine this with a radiologist, like using an ultrasound. And sometimes for a peripherally based lung lesion, we need to combine with the CT. So that's when the radiologist, the surgeon, and the pathologist come in together to get the same sample with the same concept of pricking the needle multiple times. That's how it's done. Of course, it has its advantages. You get, in case of a cystic fluid, when you get fluid, you can diagnose it with that. And if you get a good sample from the slide, like in a parotid and all, you can actually diagnose the disease with that. And then, of course, comes the true cut. You have the automatic needle where we just snap the needle, and then you have the manual one we used to use in our old time. We used to poke a needle, then put the sleeve over it, and that. So here, remember, this is not cytology. You are getting a core tissue. You're getting a proper core of biopsy into the needle, and that's sent for specimen. But the key in this is for the pathologist that we make sure we give them enough cores. Unlike biopsy where we just take a small slice, you need to take multiple cores from the tumor, at least they say 5 to 6 cores. And another way to judge your cores is that they should settle into the specimen. That's when you can say you have sent a good specimen for the pathologist to diagnose. Of course, incisional IOC doesn't need any introduction for all of us. The only thing all of us know the concept is you need to go deep and not broad. Remember, depth is important. The breadth is not important. You don't need to send a 2-centimeter sample. You can send a small sample with the correct depth is more than enough. Another thing we need to remember, like in an era when now mucor was coming up so much also, we as oncosurgeons were also getting all these mucor cases and drop-ins. So it was not just the histopathology where the specimen was dropped into, a formalin, but also it had to sometimes need culture sensitivity, fungal culture. So until unless you have a good clinical examination, you will not know where to send your specimen. So it starts from there and ends here finally. Of course, punch biopsy is another way of doing it, but this instrument I like a lot because we land up with a lot of these patients who have major trismus. You need a diagnosis for them. You can't even get your tooth like a probe inside or a forceps inside, and you don't know how to get hemostasis really. So this instrument really helps us for those kind of cases to get a good punch biopsy, send it for sampling, and then we can further go ahead. Because you can't go in for your final staging and treatment if you don't have a final diagnosis. And a small mention on the bone biopsies for cystic lesions, where you have to take a bone, but don't take the bone without the lining. There is no use, You'll send a 2 centimeter bone, nice window to the pathologist, and they will say that it's bone, what else? So always forget in bone biopsies, never forget to take the lining along with it. That's a true bone biopsy. And the whole process is same, nothing more current in this. The only thing is that they have now come up with automated machines. Before it used to be done fully manually. Of course, the excision is only done in benign cases, not in pathology so much, taking a small cuff of it. Lot of small advantages that you get the whole specimen out, you don't have to do another surgery, but then it's not a role, it doesn't have a major role in cancer. So I will also specify here, if you have a small lesion, which is looking very, very suspicious to you, please don't do a complete excisional biopsy. Preferably take a small biopsy and send it, because if you are not going to take up the patient for surgery eventually, if you are not the oncosurgeon and you're going to further refer the patient, the oncosurgeon is stuck up with where the lesion exactly lies, having a 3 centimeter suture margin, and then we are giving more wider margins to that. So you can stick to that. Ensure always good communication with the pathologist. Let it be anybody. Without that, you don't land up with a good diagnosis. See, they are not the people, always remember, who are seeing the patient. You are the one who is seeing the patient. So they are just sitting in the background. The radiologist and the pathologist are sitting in the background without any patient direct information. It's what you put in your form or what you communicate to them, which they start correlating. So never forget the good communication. A good requisition form like this, the one I started in an institute, what we thought was, if we are unable to communicate, at least get the basics into the form itself, so that the residents are tuned to writing all this, if not communicating well, so that everything comes into play, and a good pathology report, of course, then comes through. Small mention of frozen section in diagnosis. It happens that we land up with some patients who have undergone multiple biopsies, continuously coming negative, where the lesion is very suspicious, and you can't plan the treatment just because we don't have a paper diagnosis. You can do it under frozen control. Sometimes we do this frozen control biopsies under GA, like examination EUA, examination under anesthesia with a frozen control biopsy, or under sedation nowadays, so that we get a good diagnosis for a patient who's been running around and not make him undergo multiple more biopsies. That's more of a paper for margins, of course, but then it can also be used for biopsies. And of course, the imaging which comes into play, the ultrasound, the contrast enhanced CT, the PET CT, the ultrasound having its same advantages. It's a simple, inexpensive tool, very, very useful for neck lesions with early lesions. It's not an obsolete tool at all. You can easily use it for early lesions in restaurants, in cost-restrained settings. We do get patients such as that. A CT, of course, always for bone and other soft tissues, but always remember to do a contrast. Some of us have this habit of just sending a CT like we do it for trauma, like facial bones. Please don't do that. It's more easily readable. I will totally agree for a lot of us as a surgeons. And MRI has its use in soft tissue, especially when we have these high ITF patients, the neural patients having tumors which are involving the nerve, much better visualization. We may need to do double investigation that time, like a CT along with an MRI. And PET, overused in some of the metros, underused in some of the smaller cities, but the clear-cut indications being large nodes, N3, 3A, 3B nodes, lower nodes, large tumors, and of course the recurrence and salvage-setting tumors. So there are real clear-cut indications for a PET which needs to be done. You don't need to land up every T1, T2 tumor and advise a PET just because the patient feels that it's going to scan the whole body. I'm actually a little not too proponent. I will not say it's a wrong practice because some of us do it, but I'm a little not so proponent of PET if it's not indicated for a regular patient. And a small mention of our programmed death ligand 1, because it comes into diagnosis for a metastatic or a highly recurrent setting patient, because there has been shown that it has an overexpression in advanced patients with females, non-smokers and non-drinkers. The only problem being now, because multiple studies have come up and the way it is measured. So now this was actually one of the meta-analysis they did, and they found out that the cutoff, like we were using a cutoff of 10%, in this it's mission a cutoff of greater than 5% with a validated antibody and avoiding tumor microassays. The method needs to be standardized with which way you are measuring it. There have been multiple 4 to 5 methods which they are using. Why? Because when the PDL is over there, the T cell, that is the regular active system of the immunity, doesn't work, and when you stop it, when there is a big stop over there, the T cells will start working and the immunity will pick up. That's an immunotherapy which is coming into vogue. So there are good trials, Keynote trial and Checkmate trial, pembrolizumab, nivolumab being used nowadays in head and neck cancers. That's why I'm making a mention. So that is the diagnosis. It's of course done on the specimen itself. Thank you for your time.
Well, thank you so much, ma'am. We have some time. If there are none, thank you so much, ma'am. Thank you so much, ma'am. It's my personal privilege to invite the next speaker, who is a very eminent surgeon and a teacher to many of us, Dr. Anil D. Cruz, who needs no introduction.
The organizing committee for the opportunity to be here today to speak to you all on a topic dear to my heart, and that's oral cancer. Title's fancy, it's called Paradigm Shifts in the Management or in the Treatment of Oral Cancer. There's a lot happening in the field of oral cancer, but I'll just share a few thoughts with you all, more to stimulate some of the younger audience who are present here today. I bring you greetings from my new location. I used to be at the Tata Memorial Hospital, now with the Apollo Group. For those of you all who are from overseas, the largest private healthcare provider in the country, 72 hospitals, 14 cancer centers, first to have proton, and I practice at 2 places, Mumbai and Delhi. We know that oral cancer is an Indian cancer. Here is Globocan data, and you can see that the majority of oral cancers come in our part of the world, both the incidence and the mortality. And it makes sense that the research and the thought process comes from this part of the world. When I grew up, most of the literature we followed came from the West. And over the last decade or two, there have been some seminal work in our country. And I've had the pleasure of leading and being part of many of these studies, and I've just put a collage of all that has been done. And a lot of this today forms the basis of guidelines that are practiced the world over and has been thought-provoking to cause a paradigm shift in the way that we treat oral cancer. I draw your attention to the bottom 2 review articles. Again, for the youngsters, not so long back, Oral Oncology, one the current status and one future directions, which are very good reads for you all if you want to get a comprehensive overview on how to treat oral cancer. Now we know that oral cancer is a surgical disease. Barring a very few indications, there is benefit in operating patients when you see them, if they are operable. So it's a surgical disease, it's our disease. Unfortunately, we see a lot of patients with locally advanced cancers. 70 to 80% of our patients come with locally advanced, and this is not unusual for us to see in our outpatient clinics. I call some of them T6. We know that the staging stops at T4. 20% of them are just so hopelessly advanced that they're T6. And we know it's a surgical disease, so we have to do something for our patients. And we have to push the boundaries for surgery. So whenever you have a patient that is operable, and I'll share just a thought with you because I know the next speaker is speaking about resectability, so I'm not going to dwell too much. You must push the boundaries, and there has to be integration of good reconstruction for you to be able to excise these tumor. Free flaps allow you to do wider resection, lesser complications, lesser need for tracheostomy, and earlier initiation of oral feeds. Now, I still see a lot of patients who are undergoing pectoralis major, myocutaneous and other flaps. We do use them, but again, for the youngsters, it's something that you need to bring into. Free flaps have been around for a couple of decades, and it has to be part of your armamentarium if you're treating oral cancers. We know this, but where is the paradigm shift occurring? The use of more extensive flaps, and now the use of double free flaps. Case in point, patient who's had a major resection, angle to angle resection of the mandible, a lot of soft tissue and skin. We use double free flaps of fibula to reconstruct the bone and the mucosa, the anterolateral thigh flap to reconstruct the skin and soft tissue. You can see the size of the flaps that have been put in, and a fairly decent reconstruction. Or again, pushing the boundaries of someone who had this maxillary tumor, again more than half the face removed, of fibula with extensive skin taken, 4 struts made of the fibula, and as you all would agree, a fairly decent cosmetic outcome. So you have to push the boundaries for surgery, and that's where we are undergoing a shift towards more major resections. Are these worth it? Here is data of double free flaps that I've analyzed over a 2-year period. As you can see, a fairly decent disease-free survival. Out at 1 year, 2/3 of your patients are still alive. Some of these will recur, but I guess you're giving the patient the best option by pushing boundaries and doing major resections. And of course, the compartmental resection, much has been talked about it. I know Neerav's going to speak about it, so again I'll be very brief. Masticator space, infratemporal fossa space is classically described as T4B in the UICC staging, AJCC staging. Sign of relative inoperability, but most of us in our part of the world assess the infratemporal fossa. The first people who brought this was the Liao paper, looking at the infratemporal fossa into a supra and an infrastructure. And if you operated patients with those who had infrastructure involvement that's below the sigmoid notch, they do well. And you can see again the Kaplan-Meier showing that if they are properly selected, you can push the boundaries and operate patients with masticator space involvement. Again, data from our group dividing patients into T4A and T4B. You must note the line, the third bullet that I have highlighted. There's no difference in outcomes if you get negative margins. But if you don't get negative margins, then the T4B with the masticator space involvement do more poorly. So the proper selection of patients is very important. These T4B tumors also fail distantly more, but if you can operate, the outcomes are more or less similar to the T4As. So how do you select your patients with oral cancers when you push the boundaries and want to do more extensive surgery? Surgeons must be reasonably certain of negative margins. You must do good reconstruction, and you should ensure a suitable quality of life, and you should assess the biology of the disease. If you have dermal nodules, very large nodes, patient impoverished will not be able to take adjuvant treatment. Probably extensive surgery then is not indicated. Your margins must be wide, and here is a meta-analysis, and many of us excise and then go back and revise, looking at the importance of frozen section for margin control. Individual patient data we contributed to this meta-analysis. Again, please focus on the red bottom lines that I've put. Margin revision after an initially positive margins to clear based on FS guidance does not equate to an initially negative margin. So young surgeons, when you operate extensive tumors, you need to aim for negative margins upfront. You cannot go back based on frozen section, revise margins, hoping your patients would have good outcomes. But sometimes margins are uncertain. Case in point is this patient, no mandibular involvement, extensive soft tissue. Where do you place your knife? And here comes the role, and it's evolving, of neoadjuvant chemotherapy. People say there's no randomized data. There are 3 trials, all with a small number of patients, and when you look at the end point of overall survival, it's not significant. But if you wanted to have good significance in overall survival, the number of patients in these trials is horribly inadequate. You need at least 500 patients to demonstrate a 5% improvement in survival. But look at the benefits of these trials. You can shrink tumors, you can do lesser surgery, and you can predict outcomes. So again, our group probably has the largest series of 721 patients who were deemed borderline operable. You're not sure what your margins would be. Give neoadjuvant chemotherapy. Patients respond. You have better outcomes than if they did not respond. So again, pushing more patients into the realm of surgery, something that needs to be validated by more studies, but truly bringing in chemotherapy into the realm of oral surgery, which now is causing a change in the paradigm. We've also researched, and this study was led by one of our junior colleagues who's now the head of department, Dr. Chaukar, looking at chemotherapy to downstage and do more conservative surgery. Case in point, tumor paramandibular spread, no mandibular erosion, requiring a segmental mandible. Give chemotherapy, shrink the tumor, and then probably you can do lesser resection in the form of a marginal mandible. Food for thought. Is it safe? Here is a patient who I'm demonstrating from the cartoon, a real life patient. We probably would have resected the mandible in this patient because of paramandibular spread. Chemotherapy given, look at the response. Phase 2 open label study, small number of cases recently published in the JCO. 2 arms, no compromise in the DFS and OS when you gave the neoadjuvant. But look at the bottom line, in close to 50% of patients you were able to save the mandible. A phase 3 trial has now been initiated. Again, something that may cause a paradigm shift. It happened in larynx, it happened in oropharynx, it happened in hypopharynx. Who knows, in the years to come, this kind of thought process might cause us to do lesser surgeries, and we have phase 2 randomized data backing it. And the 3 studies that I showed you, Licitra, Zong, Zorat, in that little table on the randomized studies, all kind of showed the same thing. If you have a biologically good response with chemotherapy, you may be able to squeak away with smaller surgery. No talk is complete without me speaking on the neck, and I just love to do this. The long debate of whether to operate the elective neck or to wait and watch. And I think this has now been resolved. It was a long debate for over 5 decades when I started researching on it. But our randomized study showed that you save lives. 1 death is prevented for every 8 patients with an elective neck dissection, powered on a 12.5% difference in overall survival. 1 recurrence for every 4 patients that were operated, powered on a 23.6% in the disease-free survival. Subsequently, the UK study led by Ian Hutchison showed exactly the same. They had to terminate the study when our results were published. They looked at their data and showed exactly the same. Even for small tumors, you must do the neck. 8 subsequent meta-analysis, and all of them focus on the right side of the screen showing a benefit. So you must treat the neck in a clinically, radiologically node negative. But now a new debate, a new paradigm shift. Should you do an elective neck dissection or a sentinel node biopsy? And I know Atul is going to speak about that. I'm going to be brief and not take away lines from yours. Both have the advantage. And I'm sure he's going to tell you avoid the neck and you'll have less problems post-operatively. Sentinel node biopsy has been around for long. Diagnostic accuracy proven beyond doubt. And literature is replete with a lot of publications on the sentinel node biopsy. But the recent fillip came from two randomized trials. The French trial, which is called the Garrel trial, and the Japanese trial called the Hasegawa trial. Both published in JCO and both with an adequate number of patients. What did both these trials show? Sentinel node biopsy is safe. Both trials showed shoulder function is better with sentinel node, but shoulder function seemed to even out at the end of 1 year. It wasn't crippling, it was better, but it evened out at the end of 1 year. And despite these advantages, a recent publication 2019 from the US looking at T1, T2 patients who could have benefited with a sentinel node biopsy, only about 2.9% of their patients underwent sentinel node biopsy. That's because it is a difficult procedure to do. And I've kind of surmised the problems doing a sentinel node biopsy. It's safe, but we need more data because both trials were powered on a 10 to 12% difference in a non-inferiority design. The learning curve is steep to do a sentinel node biopsy. It costs more. The procedure is cumbersome in a high volume centers like in our country. It's a two-step procedure in about a third of patients. And most importantly, the morbidity is not like in breast where you have severe lymphedema. Here the morbidity is less and it peters out, evens out at the end of a year. There is an ongoing trial which is known as the NRG HN006 powered on a 5% difference with more robust endpoints for shoulder function, which probably will place sentinel node biopsy in its proper perspective. So what do we do? If you look carefully at sentinel node biopsy, you have different types of metastasis. You have occult positive, macro metastasis, micro, and ITC, which is isolated tumor cells. And here is data that I've taken out from the 3 pivotal trials on sentinel node and focus only on the 3 red bullets that I've put at the bottom of the slide. If you don't do frozen section, about a third of your patients will need a second surgery. If you do frozen section at a good volume center, this drops to 10% because occult positive macro metastasis will be picked up. Only the relevance of isolated tumor cells is debatable, and in the French trial these were not treated with no detriment to survival. So what should we do in our practice till sentinel node biopsy becomes standard of care? A pooled meta-analysis of patients looking at 2B node dissection. These were about 2,000 patients. Only 112 had 2B, which is related to the accessory nerve. And these were more in tongue cancers. And all 2B are associated with 2A. If you didn't have a 2A, only 3 patients out of this large volume of patients had 2B. So my message to you, if you're doing a node negative, don't be aggressive around the accessory. Don't pull on the accessory. There's no advantage and you won't have shoulder dysfunction. So we could circumvent bringing in sentinel node biopsy if we did a proper neck dissection and not be aggressive at level 2B. I'm concluding by saying there are a lot of paradigms that are changing in oral cancer. It's a surgical disease. Be as aggressive, but negative margins, good quality of life. Think of chemotherapy when you can't get negative margins. There is evolving data. And sentinel node biopsy seems attractive, but the shoulder function can be saved if you're not very aggressive at 2B and pulling on the accessory nerve. I end stimulating some of the youngsters. From the time I started my career in head and neck, you can see the number of publications increasing from our country. And I think you all need to build on this, and we need to go higher. As I said in my opening line, we need to have more publications for a disease that affects people in our country. So I thank you for your attention. I'll be happy if there's time to take any questions. And I leave you with an invitation for our FHNO. Rahul's here, he's one of the organizers, which is next year at Daman, which is a lovely place. So they're giving you the joys of Goa with things that are not available in Goa. So I think that will be lure for you all to come along. Thank you for having me.
Thank you so much, sir.
Next, we invite Dr. Gregorio Sanchez Genesito, a dear friend from Madrid, Spain, and he'll be speaking on operability and resectability in recurrent head and neck cancers. Over to you, Gregorio.
In India, especially in this fantastic Congress. So I will be focusing in my talk in the concepts of resectability and operability in special difficult patients, and those patients are going to be those suffering with recurrent disease for oral squamous cell carcinoma. The objectives of my talk today will be including these two aspects, focusing in these patients with recurrences, and then some diagnosis considerations, because it is especially difficult to both diagnose and then dimension the extension of the recurrence in oral cancer, and then some principles of surgical management, and of course, last but not least, personalization. As it was mentioned before, oral cancer is having a tremendous incidence in this part of the world. And of course, apart from us, let's say, spending time here talking about treatment, of course, that it is also our responsibility to fight against this disease by, working with the general population and the mass media, because of course prevention and early diagnosis is something that will lead to much better survival. Of course that globally the incidence is not so high. In Europe, where I work, it is like 25% of the incidence here, and then survival rate is highly related to how many patients with locally non-advanced stages are we treating. So the earlier we diagnose our patients, the better the results we will get. You all know about the risk factors. And then I will be using a specific case at the beginning and the end of the lecture just to discuss about personalization. This is a lady, non-alcohol or tobacco consumer, presenting with this relatively small tongue cancer, the tongue subside being the most frequent in Europe for oral cancer, and then the biopsy rendered the diagnosis of low-grade squamous cell carcinoma, well-differentiated squamous cell carcinoma. This is the imaging. So the first staging was T2N0, and then as it was mentioned before, oral cancer, both in earlier stages and advanced stages, is mostly a surgical disease. So we offer the patient some kind of glossectomy, an hemiglossectomy, supra-omohyoid neck dissection, and then a functional reconstruction with a free flap, because we have a low threshold for bringing vascularized tissue with microvascular procedures for the reconstruction. Then the pathology showed up with these margins being, one margin being, let's say, close, and then this huge dip of invasion. And dip of invasion is the new kid on the block, and then of course for us, this meaning that we need to add some adjuvant therapy to Our Lady for many reasons, not just the pathology. But this is the case that right after finishing the radiation therapy, she is presenting with pain, and then early recurrence is diagnosed. Actually, this is the tumor there invading the skin. And this is the CT scan showing a massive local and regional recurrence around the mandible. So now the question is what to do. So in this, I will be focusing in recurrence. And then, of course, you may go to your clinical guidelines. You can go to the North American clinical guidelines or European or whatever. And of course, management of recurrences for oral cancer is quite similar to management of primary cases, so surgery plays a major role whenever there are certain things to be done. I mean, whenever the patient is operable and whenever the tumor is resectable. So let's go to the literature to find out how to select, let's say, good candidates for salvage surgery. In this series, you see there that the recurrence rate in oral squamous cell carcinoma treatment is high, is up to 28%, and then for those 28%, they are just able to offer salvage treatment to 40%, 38%. And the results, the cure rate after five years, it is around 1/5. So not very promising results. So of course you need to think about whose patients will be benefiting and whose patients will not for your salvage surgery. And this is another interesting cohort. You find out that the recurrence rate is lower, probably because they treat more, early stage cancers, and then up to 66% of the recurrences are considered for salvage surgery, probably because of the previous reason too. But then it is interesting that it is clear that salvage surgery gives some options, let's say, to the patients, and if you compare the survival, it is quite a difference, when you are able to offer in a reasonable way salvage surgery to a patient, then they brought him or her to a 40% survival rate. So that's something encouraging. But of course, they also find out that whenever there has been previous concomitant adjuvant therapy, those patients did worse. It was not probably because of the adjuvant therapy itself, but because of the advanced stage of those patients. But this is helping us out to figure out how to select our eligible patients for salvage surgery. And this is the last article I want to show you. It is a cohort again of 261 patients with oral cancer, and then the recurrence rate is again around 40%, and 1/3 of those they are considered eligible for salvage surgery. And this is something that it is very important. Salvage surgery is useful just when we get an R0 margins. So if we are not convinced that we can offer our patients an R0 resection, then they will probably not be benefiting for the salvage surgery, because the survival, as in this cohort, will be quite similar to even palliative care. And we do have things to offer to our patients apart from palliative care. We have systemic treatments. So this is something very important I want you to bring home today. Patient selection is, of course, something highly relevant if you want to offer valuable salvage surgery. Of course, apart from the usual assessment, clinical and radiological, or wherever, the final decision should be always made at the head and neck tumor board in terms of resectability, operability, and then integration of treatments. As a reminder, a resectable tumor, it is not just that you can get a microscopic free margin resection, but it is also including, the concept is also including that the local control that you expect, it will be reasonable after surgery plus adjuvant therapy. And then in the assessment of the resectability, you may go to the clinical guidelines again. The multidisciplinary team is making the decisions, not just the surgeon. So sometimes it is the team bringing the patient into surgery, and then the surgeon wouldn't be the one, let's say, bringing the patient to the surgery. And that was the case that I will show you later on with the lady I showed you at the beginning. So if the recurrence is resectable, of course, that surgery is the best thing we can offer, salvage surgery. The same, I mean, that's for local regional without a recurrence, or local or regional with or without previous radiation therapy. And then apart from resectability, we need to think about operability. And operability, it is not just contraindications to surgery. It is also including that we are offering the patient an acceptable functional result. So if we leave a patient with free margins and alive, but with unacceptable functional result, we are not doing well in the 21st century. So what about salvage surgery after chemoradiation? We know about that because we operate patients having undergone chemoradiation for the oropharyngeal cancer, that it is the state-of-the-art treatment in Europe. We know that it is difficult to diagnose the recurrence itself because sometimes it's multifocal, it's usually subepithelial, and then everything is difficult to diagnose. Also the neck recurrence, because it can be contralateral, etc., etc. So we work with multiple biopsies. Pain is a sign of alarm, and then we make the decisions always with a PET-CT 4 months after the finish of the chemoradiation. So local salvage surgery is offered to our patient with a recurrence, both when the tumor is considered to be resectable with sound free margins, and the patient is considered to be operable. This including acceptable quality of life. And then another thing that it is very relevant, it is this other question. Are there other options? Because if there are no other options, then you need to lower your threshold for bringing your patient to the OR. So this means personalization. So in terms of providing with our patients with a good quality of life and then adequately reconstruct complex three-dimensional defects, we have a very low threshold for using free flaps. And then, of course, this is very helpful, let's say, with making our patient operable. Of course, again, you can go to the surgical guidelines, and if the patient is operable and the tumor is resectable, we bring the patient into surgery. So what we know from salvage surgery in the oropharynx, it is that the final outcome it is not so bad. So most of the patients will be free from tracheostomy and a gastric tube, and then they will end up with an even intelligible speech. And we know that from a few years that we are treating the recurrences of these patients primarily treated with chemoradiation. And of course, to end up with this quality of life, you need to bring vascularized tissue. So with salvage surgery and then free tissue transfer, you end up with acceptable results in the oropharynx. What about the oral cavity? As we have learned before, at some selected patients with T4 and of course some T4, I mean not just T4A, but some T4B, we don't go for surgery because we believe that, for instance, total glossectomy, it is not currently so well, let's say, reconstructed from a functional point of view. It's not very predictable that we know that we are providing our patient with a good functional status. So we more and more bring our patients needing total glossectomy or near total glossectomy to either induction chemotherapy followed by chemoradiation or chemoradiation. And this is already in the guidelines also of the European guidelines. So chemoradiation is also an option in some selected oral cancer subsites when for T4A, T4B, T4B tumors, as I will show you. So, and this is our previous patient. This is pre-chemoradiation, and then this is after chemoradiation, so complete response and tongue preservation. But of course, things happen, and then after a few months, we have this 6 months, we have this massive recurrence. So that now the patient is needing the same surgery as before, not just total glossectomy, but also significant lateral magnibulectomy because there was an invasion. And of course, when you end up with this kind of massive surgery needed, you need to discuss the real goals in a multidisciplinary team with the radiation oncologist, the medical oncologist, and then also the patient and the family. I mean, they need to be part of the decision, and then you can bring the patient to the OR and then provide him with a sound resection, and then he has been operable because the functional reconstruction has been obtained with a double free flap in the way Dr. Cruz showed us. So microvascular reconstruction is helping the patient to live without the tracheostomy and without the gastric tube after total glossectomy and significant mandibulectomy. So whose are the results we can offer our patients all in all when we bring them to salvage surgery for oral cancer? So most of them will be not needing permanent gastrostomy, but up to in between some 15 or 25% usually, and then most of them will end up with intelligible speech. In our own institution, we analyzed this kind of patients. All of them received some kind of free tissue transfer in this period of time. Perioperative mortality, flap loss, etc., complications rate were quite similar to the general primary reconstruction patients for head and neck tumors. And then, of course, the technique is tricky itself because you need to go to healthy, let's say, vessels, most of the times to the contralateral neck or to the lower neck, but all in all, you can end up with a good reconstruction. And in terms of survival, we do know what we offer our patients, and it is about 35% of survival rate after selection. So we roughly bring to salvage surgery around 50% of the patients with recurrences. So this is some analysis of the need of tracheostomy and gastrostomy in the literature, quite acceptable. So there is something to be offered to some of our patients with massive, even with massive recurrence after primary treatment for oral cancer. But of course, prognosis will be depending on mainly the resection margins. So R0 mean relatively good prognosis. R positive means bad prognosis. The bigger the recurrence, let's say the worse the prognosis again. The earlier the recurrence, the worse the prognosis, and then the same with the neck status. So if we go back to Our Lady, she is presenting with many negative, let's say, prognostic factors. This including, this cutaneous carcinomatosis. And then if we analyze the extension of the recurrence, she is needing local, regional, advanced recurrence, both locally and regionally, and needing a significant skin resection, mandibulectomy, creating a composite defect, and then it was an early recurrence, but it was the only, let's say, chance for her to be brought to the OR. So maybe it was not my decision to operate on this lady because of the extremely bad prognosis, but it was the tumor board decision. So we operated on her, we performed surgery as planned, and then we performed a double free flap. And then, of course, we knew the prognosis was very bad. But she is here 2 years after surgery, and when she self-evaluates her quality of life, she rates her overall quality of life 4 from 7, so that means quite acceptable quality of life, and she's asking for dental rehabilitation. So statistics are good, but then personalization, goes beyond statistics. So in conclusion, salvage surgery is the best option for recurrent squamous cell carcinoma of the oral cavity when reasonably, let's say, indicated. Diagnosis itself is difficult, both for the recurrence itself and then evaluating the extension, and then resectability is very important, and it should be include, reasonable potential possibility of ending up with free margins, and then operability should include also function and quality of life. And last but not least, personalization through the tumor board. And again, I want to insist in this common project we have from AOCMF with the International Academy of Oral Oncology, that it is this global oral cancer diploma that we really think it will be offering some valuable knowledge and attitude education to surgeons treating oral cancer. And if you want to get some information, you can take a picture of the QR code and then get access to all of it. Thank you very much.
Head and neck cancer. Thank you, Goyo. Thank you. Do you have a question? If we can take a few questions, 1 or 2 if somebody has. The next speaker.
It's my pleasure to invite Dr. Nirav Trivedi, who is a very close friend, an excellent surgeon and oncologist, for his keynote lecture on recent trends in surgical approaches to oral and maxillofacial cancers. Welcome, Dr. Nirav.
About surgical approaches for oral and maxillofacial cancer. We can broadly classify them into open and minimal invasive approaches, and we all know that for oral and PNS cancer, role of minimal invasive surgery is restricted. So when you select an appropriate approach for a particular patient, prioritizing what is important is of paramount essentiality. We have to remember that we are going to deal with cancer. So adequate exposure to achieve negative margins in all 3 dimensions is of extreme essence. Then comes functional morbidity, and then comes cosmesis. So what are the factors that influence in choice of approach? It's surgical anatomy, extent of disease spread, anterior versus posterior location, deeply infiltrative tumor versus exophytic tumor. For Indian patient, submucous fibrosis, and surgeon's experience and training. Now remember that approach is to select and offer a good margin control to patient, and not to prove that you are a good surgeon. Today I am going to take various sites and discuss common approaches that we choose. For a pre-cancer, low risk, either you observe or do an incision biopsy. But if you decide to excise any pre-cancer, in your mind, it should be at least a carcinoma in situ. Take 5 millimeter mucosal margin, and when you resect deep, at least take 5 millimeter cuff of muscle tissue. This will avoid a situation where you have just done a superficial excision and biopsy turns out to be a carcinoma in situ or an invasive cancer. So if you resect, just keep in mind that it should be at least a carcinoma in situ type of a resection. We all know that management of N0 neck, a selective neck dissection is sufficient. It's also sufficient for 1 or 2 lymph nodes in the upper level. You only do modified neck dissection when nodes are at multiple level or in level 3 and 4. Do not unnecessarily sacrifice a sternocleidomastoid, spinal accessory nerve and internal jugular vein. So now first picture is a conventional way of doing a selective neck dissection, the incision. There are 2 vertical limbs. Now central vertical limb, anterior vertical limb is not necessary. It gives a bad scar. So you can avoid that and go onto the opposite side if you really want a good access to level 1A. But posterior limb is actually hidden in hair, and that will give you a very easy access to level 2B resection. Without having to stretch too much, we can simply remove level 2B without disturbing spinal accessory nerve. So in my opinion, particularly when you are starting, you should consider this particular extension. We should all learn how to preserve marginal mandibular nerve, ligate facial vessels below, and then flip it up, and you will be saving the marginal. Now neck dissection is actually a fascia to fascia dissection, and if you understand microanatomy, you can start your dissection from one muscle plane from digastric anteriorly to mylohyoid, remove level 1A, then dissect posterior belly of digastric and anterior body of sternocleidomastoid muscle, and take all the tissue from one fascia to another fascia to internal jugular fascia and out. It will become a very simple and straightforward procedure. If nodes are more extensive, you may have to do a modified neck dissection, a radical neck dissection, or in certain cases, extended neck dissection. Now this is something new, post-auricular incision for neck dissection, generally used by robotic or laparoscopic resections, but if you extend a vertical limb slightly lower, even you can, with open instrument, you can complete your neck. Coming on to parotid surgery. One of the most essential part of the surgery is identifying the facial trunk. Always have a wider approach. Dissect posterior belly of digastric and tragal pointer and work in that broad plane so that you can easily dissect facial nerve. A small blood vessel comes just before the facial nerve. You clip them or buzz them, and then you can identify the nerve. Never work in a small hole because the nerve is at quite depth and you will struggle. Sometimes you face with deep lobe tumors. The process is you identify the trunk, remove the superficial lobe. Most of the time your deep lobe will be, the lesion will be between 2 stretched out branches of the facial nerve. You have to be gently teasing the nerves away and then gently mobilizing the deep lobe. A word about facial nerve monitoring. It is not needed for routine cases. If you really want to be careful, ask your anesthetist not to give long-acting muscle relaxant. So when your cautery is near nerve, the nerve will tweak and you will know. Many people use it for recurrent cases. I have personally not used it, and I generally follow a retrograde method, identifying one of the peripheral branches if I am struggling to identify the main trunk. Parapharyngeal space is divided into pre-styloid and post-styloid, and for pre-styloid consists of deep lobe of parotid, minor cervical and some lymph nodes, while post-styloid consists of carotid sheath. Pre-styloid tumors, the imaging is a cornerstone for diagnosing a parapharyngeal space tumor. If you have a suspicion of parapharyngeal tumor, do not do an FNAC upfront. Get an imaging done, and if there is no vascular lesion, then only put a needle in. Post-styloid tumors are generally approached via transcervical route, and you need to have understanding about anatomy of your carotid sheath structures. I have seen many people directly, when they expose the neck, directly try to remove tumor. Always identify your important structure first: the internal jugular vein, carotid vessel, vagus, spinal accessory, and hypoglossal. And then kind of separate them apart from the lesion. This way you will prevent injuring any of them, and while you separate them from the tumor is already dissected, you just have to remove the tumor. Pre-styloid tumors can be approached either by transparotid approach, or a mandibulotomy approach, or a transcervical approach. Nowadays we rarely do a mandibulotomy and most of the lesions can be resected by a transcervical approach. So you identify the digastric posterior belly, ligate the facial vessel, and flip the submandibular gland anteriorly. You'll create space in that area, and with around capsule dissection, most of the tumors can be teased out. Sorry. Coming on to buccal mucosa, anatomically we can divide into two separate aspects: anterior buccal mucosa and posterior buccal mucosa, which extends into infratemporal space or masticator space. For anterior buccal mucosa, anatomy from inside out is mucosa, submucosa, buccinator, subcutaneous tissue, and skin. When are you going to do segment mandible versus marginal mandible? So when there is a significant paramandibular spread, gross cortical erosion of bone, marrow invasion, you have to do a segment mandible. Then if it's post-radiated patient or edentulous patient, these are relative contraindications for marginal mandible. Another question which we face in day-to-day life: are you going to take skin when you resect a buccal mucosa tumor, or you are going to preserve skin? So I have a policy, thank you. I have a policy that if a tumor has penetrated buccinator and gone into subcutaneous tissue, I generally take an ellipse of skin around that area to ensure that my deep margins are fine. So I pinch. If pinch consists of skin as well as significant amount of subcutaneous tissue, I preserve skin. But if it's a very narrow pinch or it's difficult to pinch, then I would sacrifice the skin. Are we going to do lip split or intraoral resection? Any patient with significant submucous fibrosis, I always do a lip split. If you try and do an intraoral resection for severe SMF, while you put retractors, those retractors will tear your buccal mucosa. There will be bleeding, you will lose your margins, and it will be a mess. Also, for relatively posterior lesions in oral cavity, if there is even limited submucous fibrosis, try and do a lip split. Which lip split? Midline or angle of mouth? So if your resection margin is coming all the way till commissure, always do an angle lip split. Because if you do a midline lip split for this type of lesions, in between area will get necros because of lack of vascularity. Reconstruction of commissure is an essential part of oral cancer buccal mucosa resection. When you have resected commissure, which is quite often in these cases, always try to ensure a competent lip closure and a competent commissure. Either you can stitch the lip together, one on each other, or if you are going to stitch it to a flap, deepithelialized flap, always use a facial atlas link. Remember, microstomia with a competent lip is always better compared to a macrostomia but incompetent lip. Coming on to infratemporal fossa, as DeCruz sir pointed out, Liao et al. Proposed a classification of infranotch versus supranotch. And they said infranotch outcome was very good, supranotch was not good. But in that series, supranotch were only 8 patients and 3 out of 8 were actually doing fine. Based on our work, we have proposed a subclassification for supranotch lesion where it's divided into low supranotch versus high supranotch. So what is this low supranotch? Is all the structures involved in supranotch but not involving to pterygomaxillary fissure, foramen ovale or sphenoid bone. And we feel that if adequate surgical resection is done, there is a potential for this tumor to still be cured. The concept of compartment surgery is we remove all the content of infratemporal fossa irrespective of extent of spread within the ITF. There are many benefits of this procedure. Because it's the same procedure, once you get used to it, it becomes a straightforward procedure. The bleeding is significantly less, and recurrences or residual tumor because of technical means is almost negligible because you are removing the entire compartment every single time. Coming on to tongue cancer, we can broadly divide into anterior, posterior, medial, lateral, superior and inferior aspect. Now, anterior, lateral or superficial lesions can be easily accessed intraorally if there is no SMF. Always remember for tongue cancer, palpate the induration and go around 1.5 centimeter and keep palpating it while you are going in the depth. If the similar lesion has a significant SMF, I can put a small lateral lip split incision, remove 2-3 teeth upper and lower jaw, and if I use a jaw stretcher, I'll get a 2.5 centimeter mouth opening and I shall be able to remove that tumor. But for a case where the tumor is lateral and inferiorly going into floor of mouth and hyoglossus muscle, if I try to do intraoral resection, there is a chance that I will miss some lesion in the hyoglossus muscle. So instead of doing intraoral resection, I can actually go from the neck, hug the medial border of the mandible, release mylohyoid muscle and the medial pterygoid muscle, medial to medial pterygoid muscle, free the entire lateral aspect of the tongue, then make anterior cuts and then bring the tongue down, palpate the lesion and get my posterior margin based on the induration. Similar approach can be used for posterior lesion, posterior third lesion going on to base tongue. Instead of going from anterior, just enter through vallecula, palpate the tongue, go through lateral pharyngeal wall. I'll show in my next talk how you do it and then get the entire tumor out in a 3 dimension. A similar approach can be used for oropharynx tumor as well. We know oropharynx can be approached either by transoral robotic surgery or by transmandibular approach, but we use a transpharyngeal approach to do that, and we use the anatomy of parapharynx space. You can see in the center photograph, the parapharynx space is traversed by branches of external carotid artery from lateral to the pharyngeal tube. So if I ligate those vessels, I can create a very nice avascular plane in between, and I can palpate the tumor in the pharynx tube and then get a nice adequate margins all around. So without doing a mandibulotomy, like in the third photograph, you can see there is a uvula epiglottis. So entire base tongue was resected just by transpharyngeal approach, and you anyway make this incision because you are going to do a neck dissection. This can also be done for patients with submucous fibrosis, which is a contraindication for a transoral robotic surgery. TORS is an established procedure in a trained hand, generally used for early lesions, but cannot be used for SMS and still a bit expensive. Coming on to maxillary and ethmoid tumors, if tumor comes out anteriorly, you need to approach one of the conventional anterior approaches, but if tumor has penetrated through posterolateral wall into infratemporal fossa, you have to have one of the transmandibular approaches. And just a word, when you do a palatal excision, if it's malignancy, try to take bone along with it, just don't do mucoperiosteum stripping. If it's an early lesion into lateral nasal wall, a lateral rhinotomy suffices, and you can do a medial maxillotomy and remove the lesion. If it's an infrastructure maxillectomy, are you going to do intraorally or with a lateral rhinotomy? So I do intraoral only if there is no SMF, relatively anterior lesion, bone is involved only at a lower level, and I am confident enough to control bleeding of internal maxillary artery when I cut the posterolateral wall. Even today, most of my infrastructure maxillectomy I try to do with lateral rhinotomy. If it's an anterior tumor coming out of subcutaneous tissue or going upwards into ethmoids, you use a Weber-Ferguson incision and do a conventional maxillectomy. But if tumor has breached posterolateral wall and gone into infratemporal fossa, anterior approach is never going to be sufficient. So you have to do a transmandibular mandibulotomy approach, which Dr. Ram Mohan Tiwari sir and Moni sir and Shilpa has very elegantly demonstrated. You do a mandibular swing, detach all the pterygoid muscles and remove them en bloc with maxilla. This mandibulotomy you have to put it back, and after radiotherapy they have a significant trismus. So then we modified this approach with an angle mandibulectomy. So you just remove a centimeter of mandible at a coronoid level. This kind of creates a cantilever but has significantly better mouth opening even after radiotherapy. For an orbit excision, if there is a large volume, difficult to go all the way to the apex. So what I do is just take a simple central piece of orbital floor out so that I can put my right angle from below till the orbital apex, can easily clamp the apex and remove the large chunk bulky orbital mass. Coming on to craniofacial resection, either it can be open or endoscopic. And when you have to do an open procedure, you have to combine the transfacial approach with transcranial approach. Common transcranial approach is bicoronal flap and frontal craniotomy. But in a select cases, if frontal sinus is well pneumatized and a large size, you can use a Raves subcranial approach. Transfacial approach could be lateral rhinotomy, midfacial degloving, or a Weber-Ferguson. Now, I don't have any experience with endoscopic craniofacial resection, but it is a well-established procedure in trained hand. Now, if you want to do this, you should have complete exposure to all open approaches. You should also be very good with endoscopic benign procedures, and you should always have a neurosurgeon standby in your team. So if you don't have any of this, don't feel ashamed to do a standard open craniofacial resection. To summarize, I would say, no single approach is appropriate for all your lesions. So you have to understand what are your priorities and then plan an approach. Also remember that in cancer, as all seniors have been telling since morning, adequate margin control is of prime essence. So that should be your priority. And again, a small incision in cancer is not going to make you a big surgeon. So feel free to have adequate exposure and select appropriate approach. Thank you.
Thank you, Dr. Nirav, for this comprehensive. If you do not have any questions, we move on to our next topic.
Yeah, the last talk in this session will be by Dr. Atul Kusnale, our very own maxillofacial surgeon who's trained here and then shifted to UK. He'll be speaking on sentinel lymph node biopsy in head and neck oncology, rationale and my experience. Over to you, Atul.
Thank you. Thank you for inviting. 10, 12 years, and I have got my own views about it. And as it has evolved, I think the evolution of sentinel lymph node biopsy and treatment has also changed. That's where I work on the South Coast. And this is what I would probably like to address. A little bit about sentinel lymph node, the history, bit of rationale. I do for melanoma, that is majority of my practice, but sentinel lymph node biopsy in oral squamous cell carcinoma, as Anil has put, is also changing the paradigms. Some people in Europe and United Kingdom are becoming more and more pessimistic about it, and I think it's an important thing. It is controversial, but any change is always difficult, and so we will just touch base to that, and I will discuss about my practice and how the setup took up and what our experience is in UHD, and also briefly touch base with where I trained in Glasgow and what is the future of sentinel lymph node biopsy really if you want to bring it in your practice. So sentinel lymph node biopsy is not a new thing. In 1960 it was first described for a subdigastric node, and then it has been used for breast cancer because axillary lymphadenectomy is high morbidity procedure. Then Cabanas described it for penile cancer after lymphatic mapping. And Taimur Shoaib and David Suter in Glasgow, Canisbane started using it for head and neck cancer. And I think they were the first ones to describe the triple therapy for sentinel lymph node biopsy, i.e. the radionuclear dye, the SPECT CT, and a patent or a methylene blue dye to be used. So they had a first conference in Glasgow, and I think it died a death, then got revived again by Professor McGurk from London. And I think it all stems from minimal access, not to do, and during the same time, Anil's paper came from Tata Memorial Hospital, and we had Ian Hutchinson's paper, which really put the nail in the coffin for anything else, especially the wait and watch policy. So elective neck dissection has become. Now remember, sentinel lymph node biopsy came into mainstream suddenly, which in United Kingdom, because it was recommended as best practice by NICE guidelines. And I think it just sneaked in, and that was based on AJCC 7 and not on the AJCC 8, and so we'll just briefly talk about it. So what is sentinel lymph node biopsy? It's a minimal invasive procedure to identify patients harboring occult nodal disease. It identifies those patients which will require adjuvant therapy like immunotherapy or radiotherapy. For melanoma, I'll just briefly talk about that because I think it is well accepted. So when I started, it was not, and now it has become mainstream. It is required for all melanoma practitioners. 80% of melanoma patients with regional disease, the morbidity of a neck dissection and parotidectomy outweighs the risk, and so we don't want to do that. So in melanoma, we have the melanoma focus guidelines of United Kingdom in 1918. And this was published against in JEPRAS as a current role of sentinel lymph node biopsy in the management of cutaneous melanoma. So sentinel lymph node biopsy is indicated with all primary cutaneous head and neck melanomas of PT2A and above. And with PT1B, you need to look at certain characteristics of the melanoma itself, whether it has got a lymphovascular invasion or a mitotic rate of more than 2 per millimeter square. When I started, there was a lot of discussion about MSLT trials 1, 2, and 3, and as a result, there was lots of resistance to sentinel lymph node biopsy service. But the recent changes with immunotherapy meant that there is a revamp in the thinking, and so the melanoma focus felt strongly that MSLT1 data is now outdated, and it is recommended the NICE guidelines are now revised and reviewed urgently. They have not yet been revised. So is there any role for elective neck dissection in a melanoma? Absolutely not. There is enough prospective trials. The MSLT did not show any overall survival at all, so clearly that is now done case, and there is no argument there. There are quite strong evidence on the randomized controlled trial. So is completion neck dissection then recommended? Not for all primary head and neck melanomas. So on select cases, yes, you need to do completion neck dissection. Because surgical salvage after adjuvant treatment is very complex in head and neck, where there is macroscopic nodal disease, and I think that is an important point to bear. The potential for this surgical morbidity and the expectation of receiving post-operative radiotherapy means that this patient require careful monitoring. Now, when you are discussing all these things, it is more of a joint management with the oncologist, and the plan should be individualized to that patient. Melanoma patients tend to be more into the 40 plus age group, and some of them are in the 70 plus age group, so there are lots of comorbidities, and I will just come to that in terms of immunotherapy. So the completion neck dissection in melanoma should be considered for those patients with features identified on their sentinel lymph node biopsy that indicate high risk of regional relapse. So if they have got extranodal extension, more than 3 involved nodes, and DEVOR criteria for multifocal or extensive melanoma. And those who are unsuitable for adjuvant therapy, like the immunotherapy, either due to medical comorbidities or where geographical constraints may limit access to routine follow-up in a regional cancer center. Some of it is quite controversial, and you need to have a robust debate in the multidisciplinary team meeting or the tumor board. So what is the importance for sentinel lymph node? It is incorporated within the AJCC. It is good staging mechanism. It is very sensitive and specific modality of regional staging. The negative predictive value, which is very important, is 95.8%. It's an important figure for melanoma. Patients with local control and negative sentinel lymph node failed in the regional basin, and note the figure, it's only 4.2% of cases. So it's quite important, and that is where the shift has happened in melanoma's practice in head and neck. Oral cancer is completely different kettle of fish now. The NICE guidelines, as I just mentioned, is United Kingdom's body, which is an independent and gives guidance about best practice and not based on any financial political basis. 2016 on AJCC 7, they recommended sentinel lymph node biopsy. Most of us were quite surprised that this sneaked into our practice. Suddenly, the tumor boards or the multidisciplinary teams were faced with the prospect of incorporating a practice which was expensive, needed training, and we all knew that it needed steep learning curve as well. Not many surgeons were prepared to do that. Suddenly there were not many regional centers, so lots of things just spun out. It was indicated for T1, T2 tumors with N0 neck. And the rationale was that elective neck dissection through all the randomized controlled trial, 60 to 80% patients who may not get occult disease were subjected to an elective neck dissection and the morbidity. So the proponents said that 20% of patients are unnecessarily, 80% of patients unnecessarily subjected to this morbidity. It did not address the contralateral neck nodes. Skip metastases are not picked up. I will come to that in a minute. The theory is that tumor doesn't understand the levels in the neck. What is published, even through the randomized controlled trials, is best guess. Best guess is like a game of probability. A game of probability is gambling. So, when you're talking to a patient, you're just telling them that the probability of you getting a nodal metastasis is X and Z based on the evidence that there is, yet it is a gamble. The probability exceeds 50%, and that's the only positive thing about the randomized controlled trial. Now, the contralateral neck and ipsilateral neck as well, the failure after elective neck dissection is an important factor. And what is the salvage? One of the previous presenters here talked about salvage, and the salvage in a neck recurrence is poor. And as a result of that, you need to be aware of any other modality that will help to adjunct as an adjunct with your neck dissection. And I think that is where my practice is moving now. So Mark McGurk answered to my close friend Panos and Vasilius, who presented their data, and really the robust data in EACMS position paper. I think a few of my colleagues are here. And just few things he said. So Mark McGurk thinks that the false negative rate in sentinel lymph node is almost similar to an elective neck dissection. Now, elective neck dissection doesn't have an FNR. It has got a neck recurrence rate of around 15 to 20%. But note this thing, elective neck dissection, not all lymph nodes are subjected to scrutiny. So they are understaged by 15%, which does not happen with sentinel lymph node biopsy. So 15% of time you are missing the nodal disease in elective neck dissection. Skip lesions are missed. Contralateral neck is not addressed in elective neck dissection. And we know when the depth of invasion And whilst there are not robust studies about the contralateral neck and randomized control trial, but there is enough data to now suggest what happens. Local regional control, I've just mentioned to you about the isolated neck recurrence of around 7.5 to 10%, which is similar in both limbs here. But the salvage rate, very important. So when you've got a failure in the neck following elective neck dissection, look at the salvage rate. It is poor, 20%. Gregorio just showed us that. All the data that he's accumulated and presented points that. The salvage rate with a sentinel lymph node is a two-stage process anyway. If you got a sentinel lymph node biopsy positive, you've got an 85% chance of salvaging. However, I will come to a little caveat there. I think it is much more a difficult neck dissection compared to an elective neck dissection if you're doing a salvage. I think that's the thing. Adjuvant treatment planning. And I will also briefly tell you about this, that it all puts things into perspective. Suddenly you are hit by COVID. The second stage following a sentinel lymph node biopsy, which was positive, the delay can be disastrous. And I have a patient who will be lost as a result of that. So that delay is important. It also needs to be on an accurate pathological assessment. And as I said, elective neck dissection will miss 15%. So what were the goals for oral squamous cell carcinoma and a sentinel lymph node biopsy? It was to improve the staging, reduce the morbidity, and it should be cost efficacious. That is what it was thought, that patients would be operated and sent home. Happens in around 80% of time and should be as effective as elective neck dissection. Okay, so just briefly telling you, as I said, when it was spun on to us, it was very difficult for us to then understand how do we get everything together. It is a teamwork, as suddenly we have to assemble a new team to start this. We need to get the equipment, we need to have the knowledge of everything, and it is skill-based, so you need to be trained. And it is just like an ultrasound. It is all based on the person who is doing it and how meticulous that person is. And so this is our team. It is a collaborative effort between the surgeon, the dermatologist for me with my melanoma practice, with nuclear medicine staff, the radiologist, pathologist, the nurse specialist. So I had to take whole of the team to a training center so that we align our practices in the same manner. Now I will tell you, because I'm very pedantic about few things, the nuclear medicine, the amount of dye that is given, the time duration from the dye to the operation, all that important things will determine whether you will get a positive or a negative results. So what are the practical steps? You get a staging scan, you stage it as an N-knot neck, then you do peritumoral injection of technetium-99m radionuclear dye. We use around 80 to 88 MEBQ peritumoral injection. Then the patient is subjected to dynamic and static lymphoscintigraphy using a single photon emission tomography and CT. They are fused together, and nowadays you can get a 3D system as well. Incorporated draining lymph node is marked on the skin. Again, this has to be standardized, because when they are doing a SPECT CT, the patient is lying not on a head ring but on a pillow, and they mark it, it moves, and so that is an important thing to bear in mind. Intraoperatively, I give patent V blue. I have not encountered, touch wood, any anaphylactic reactions to it, and then a gamma probe is used to harvest. This is the kind of nuclear medicine. The first figure here is the static one, and the second one is the dynamic one over the time, and you just find the primary nodes and the secondary nodes and what is the uptake and how big is the uptake. So traditionally this is what we would do. You would use the gamma probe, you would mark it 1 centimeter all around it, and then resect it. Okay, I will get to the point. I inject patent blue. That makes anatomical assessment very difficult, because everything is stained blue, as you can see in the specimen. Here again, you can see that we've opened the neck up, and we are just trying to find if there is a anterior tongue. You need to go into the submyelohyoid
Thank you so much.
Thank you.
With this, we come to the end of this first session in Grand Hall, and then next we start with the much awaited grand debate in oral oncology. And may I invite...
Sir, sorry to interrupt you here. Before that, we have a very small speakers for this session. I request Honorable Chairperson, Dr. Nitin Bhola sir and Dr. Stage, please. I call upon Dr. Moni Abraham Kurioko, sir. Sir is not here.